Good morning, and on behalf of the Duke Margolis Center for Health Policy, I'm Mark McClellan. I'd like to welcome you to today's webinar on promising practices for improving the use of COVID-19 monoclonal antibodies. We've set this up as a timely and packed discussion on the effective use of monoclonal antibody treatments for COVID-19. These are the man-made antibodies designed to target the SARS-CoV-2 virus as well as the emerging variants. It's an important complement to vaccines for people who are not vaccinated or who aren't able to mount a strong response, and also potentially to help with containing outbreaks involving variant versions of the virus. Right now, these treatments are approved for certain high-risk patients, people who are over 65 and with other risk factors for COVID-19 complications. Several of these antibody treatments are authorized for emergency use now. We're going to cover these treatments as well as a growing range of promising practices that we're seeing among providers, states, and others who are taking action to improve access to antibody treatment. Effective use requires a more proactive approach to the early stage management of people with COVID, meaning rapid diagnosis and rapid action on that diagnosis, and also requires the development of the capacity to provide timely infusion access for these infected patients. This is an important topic now because antibody use remains well below the available supply. By recent estimates, only about 30 to 40% of available antibodies have been used in these high-risk patients. Now, fortunately, in the United States, cases and hospitalizations are falling, but tens of thousands of high-risk patients continue to be infected daily, who end up often in the hospital or with serious complications, many of whom could potentially benefit from antibody use. The Duke Margolis Center for Health Policies released two recent reports related to the reasons for this limited access. Last week, in collaboration with former FDA Commissioner Robert Califf, we released a report on the state of the evidence and opportunities to fill evidence gaps related to COVID-19 antibody use. And this morning, we're releasing a report on as well as some resource guides for all those involved in COVID-19 early stage management on the effective use, effective strategies for monoclonal antibody access. That includes primary care providers, health systems, COVID testing centers, potential infusion centers for the antibodies, nursing homes, and other high-risk settings. So we're looking forward to a lively discussion on these topics today. We're going to start with a fireside chat, as it was, between Scott Gottlieb and me. We'll talk a little bit about an overview of where we currently are in the pandemic and how these antibody treatments, if used effectively and appropriately, could potentially help as part of a comprehensive response strategy. We'll then hear from senior medical leaders at Eli Lilly and Regeneron, two of the companies with antibody treatments currently available under the emergency use authorizations. They'll share an update on the evidence base and their ongoing clinical development programs. We'll talk more broadly about the range of monoclonal antibodies in development and in modification. We'll then turn our attention to the states. States have been integral partners in the response to COVID-19, especially the frontline allocation of antibody treatments. Those treatments are now purchased by the federal government under the emergency use authorizations, but states have helped in their distribution and access. We're then going to spend a session highlighting the promising approaches and strategies for further improving antibody access, that focus of that report that was released this morning. And we're going to close with a forward-looking discussion about some of the important challenges ahead related to evidence generation, related to payment, related to adapting monoclonal antibodies along with the changing nature of the pandemic. So lots to discuss today. Just a couple of housekeeping notes. We're recording this webcast. It'll be available at the Duke Margolis website following the event. For our speakers, you'll be muted during the duration of the webcast, and so we ask you to turn on your video, unmute when we get to your session. And for those who are joining us today, thanks for being with us. If you're joining via YouTube, we've enabled one-way chat functionality there. So if you'd like to pose a question during the moderated discussion phase, please type it in and we'll receive it. We'll try to work it into the discussion. Also want to disclose that I'm a board member at Johnson & Johnson, which is working on vaccine products, though not monoclonal products in this space. So Scott, I'd like to turn to some discussion with you of the issues before us right now. Maybe first we could start on the big picture. In many ways, it seems like we're starting to emerge from the pandemic. The cases are declining after that double surge following the holidays, as I alluded to earlier. But we're making progress on vaccination. Still seems like a long way to go, but more than 10% of the eligible adult population has already gotten at least one shot. Millions more seem ready to do so as the vaccine supply ramps up. But it doesn't quite feel different yet. We still have quite high levels of hospitalizations. Restrictions are still in place. There's an expectation that vaccination is going to be the way that this pandemic ends in some form, but it's not yet clear what exactly that's going to look like. Although if you look at places like Israel, they're starting to reopen activities for people who have been vaccinated or have immunity to COVID. So in light of the report that we released today, I want to talk a little bit about how monoclonal antibodies fit into the future here. But first, about the future. Can you talk a little bit about what happens from here? I know you've been thinking about this a lot.
Yeah, thanks, Mark, and thanks for having me. I'm optimistic about the future. I think we're seeing an improving picture. Still a lot of death and disease from COVID around the country, but an improving picture nonetheless. And I think that we're in a position where we have the tools and a game plan that can help us lock in the improvements and prepare for the future, including the risk from the new variants. I think we're likely to see continued declines in infection across the country, in part because we now have at least a third of the population that has had COVID and has some protective immunity. That's certainly not herd immunity, but it's impacting the RT, the rate of transfer. We're seeing mobility data come down. I think that that's a big factor in why we've seen a decline in the rate of infection. Google mobility data has been a really good predictor of the ebbs and flows of this epidemic. And we saw a real decline in mobility after the holidays. I think that was in part people reacting to the level of infection around the country. I think it's also in part probably people recognizing that they're going to be getting vaccinated soon and being a little bit more cautious ahead of vaccination, not wanting to get COVID right before they're on the cusp of getting vaccinated. I think that, you know, the leadership and the rhetoric around the prudence of wearing masks and taking precautions certainly is probably having an impact on the R, probably knocking 0.2 to 0.3 off of it in terms of just conditioning behavior differently. And I think we may be starting to see the impact now of vaccination. You have about 10% of the population that's been vaccinated at this point or approaching that. And you're going to start to see the impact on the margin of the rising rates of vaccinations. On the variants, you know, these obviously represent a real risk, but I think a risk to the future and a risk that we have the tools now to prepare for, both in terms of how we re-engineer the vaccines in time for the fall, which we have the opportunity to do, as well as the antibodies and how we evolve the antibodies. My estimate is, and as you know, I'm on the board of Illumina, which is filtering a lot of the data around the new variants. I'm also on the board of Pfizer, just getting that disclaimer in. But our estimate is that the prevalence of B117 is probably more like 1%. CDC has talked about 4%. I think that that's an artifact of oversampling hotspots. And so we're getting a skewed perception of what the true prevalence is around the country. There's clearly parts of the country that are hotspots, and we're likely to see regionalized effects because of B117, where, you know, Florida may have a protracted epidemic, or Southern California, but other parts of the country, the prevalence is quite low, outside probably of some isolated hotspots that we're not fully detecting. With respect to P1 and B1351, the South African, the Brazilian variant, we're not sure that those are more fit. Part of the theory is that they pierce prior immunity, and that's why they become prevalent in those markets, but it's not clear that they're necessarily more contagious like B117. But the assumption is that the prevalence of those is well under 1%, probably 0.2%, 0.3% right now in the US, and not growing as quickly. So they represent a risk, but they're a risk that we have time to try to develop countermeasures against, and that we have the opportunity to get right if we make the right decisions now. So I think that they're a manageable threat right now. So my overall perception is that the picture is improving, and we have the tools and capability to lock in those gains and secure certainly a better spring and summer, and hopefully reduce the risk going into the next fall and winter season.
Yeah, looking ahead over the next few months, it does seem like this is a version of, pandemic fatigue, but we're seeing less use of testing, partly because the rate of infections is coming down, and maybe some sense that say monoclonals therapies aren't going to be as critical going forward. Can you say a little bit about, as you look out a few months and longer from now, how the therapeutics are likely to fit into this future picture, given that not everybody may be vaccinated and not everybody may be able to mount an immune response to vaccination if they are, and maybe some concerns about the variants, which, as you say, are not widespread now, but they are out there and they are going to remain a threat.
Yeah, I mean, I think testing's coming down, to your point, because infection levels are coming down. Testing drives cases, but cases drive testing. People get tested when they're symptomatic. They get tested when they're exposed to COVID, and so as cases come down, testing comes down. But there's actually more testing, I think, in the market than even we're capturing. Even on sequencing, CDC talks about a couple of thousand sequences that are being done every week. Those are the sequences that CDC is doing and the ones that they're contracting for. There's actually about 20,000 sequences being done a week looking for P1, B1351. The public health labs alone are doing 4,000 sequences a week on their own. It's not all getting reported into CDC. So it looks like there's a lot less sequencing going on in the country than what's actually occurring in terms of monitoring for these new variants. I think, looking out over the summer, hopefully we're going to have a situation where the prevalence is going to sharply decline. I think if B117 wasn't in the picture, we'd have a completely quiescent summer. I think with B117, we're probably going to have some persistent spread and some hotspots around the country. But, testing is going to come down. Utilization of these therapeutics is going to come down. I think the risk is really to the fall, where we have to think about, how we're going to deal with the first sort of normal season with COVID. COVID is going to start to become a more normal part of life that we're going to have to deal with. And, that's going to be trying to get vaccination levels up. But also, I think the antibodies are going to continue to fit into the picture for people who either can't get vaccinated, people for whom the vaccines aren't effective. We may want to use the antibodies as prophylaxis in very high risk people who are on chemotherapy, elderly individuals who have multiple comorbidities where the vaccine may not be enough and you may want to prophylax them. So I think we're going to have to think about how the antibodies fit into sort of a therapeutic picture where they're a backbone of therapy, not just a drug used as they're being used now to rescue certain patients who meet certain risk parameters, but as a more mainstay part of therapy. And the other thing that we may have by the fall that we really haven't factored in is a small molecule inhibitor of viral replication. I mean, we that could be a real game changer. I don't think that obviates the use of antibodies. I think there's going to be a therapeutic space for both of those modalities, but we may well have a small molecule inhibitor of viral replication by the fall that we haven't even really thought about.
Yeah. So I'd like to bring in two other perspectives of discussion now, as it seems like as we look ahead with the potential long-term need for monoclonals, antivirals, as you said, as part of a comprehensive ability to keep the virus contained for the long term. I'd like to bring in George Yancopoulos, who's co-founder, president, and chief scientific officer at Regeneron, and David Stovronski, who's senior vice president and chief scientific officer at Eli Lilly, who've been involved in bringing some of these antibody treatments to market. You all, one of the barriers to use, or why they haven't become more widespread, is concerns about the state of the evidence. That's getting better, as we covered in our recent report, but I'd appreciate any brief comments you all have on that or on any other topics related to the emerging effective use of monoclonal treatments. And George, maybe we could start with you for a few minutes, then go to David, and like to bring Scott back in for some follow-up discussion.
Thanks, Mark, and thanks for the opportunity to participate. I had a slide presentation planned, but we probably don't have time for that. So instead, let me just address some of the issues that have already been brought up. First and foremost, I have to give some backgrounds about the antibody therapies. I think that there's a lot of similarities between our data and the Lilly data, but there are also some important differences. I think both have demonstrated definitive antiviral activity, that is the ability to rapidly and robustly drop viral levels in the first few days of treatment. The antibodies are the only class of treatment able to do that, and I think that that's obviously really important. If if you want to block the virus, you want to be able to demonstrate profound antiviral activity, and the antibody approaches have shown that. And I think both Lilly's and our antibody cocktail have shown the ability to really impact outpatient disease from progressing to more severe disease, and also to powerfully prevent infection in high-risk individuals. But there are some differences in our data. Right now, we have the only early data, it is still early, suggesting that antibody treatment may also prevent the hospitalized patients from progressing and dying. That could be a very important use of these antibody approaches. And another important difference right now that I have to point out is that we uniquely and prospectively designed our cocktail so as to maintain effectiveness against the emerging variants. As we published in Science all the way back in June, we actually predicted the mutations in some of the most concerning emerging variants, such as those from South Africa and Brazil, and we intelligently designed a cocktail to withstand these mutations. And I think that's a really important point, because I think the ability to target patients at all stages of the disease, particularly in hospitals, though, as you guys have said, right now the numbers are down, but there's still about 50 or 100,000 people in the hospital, about 2,000 dying every single day. Any impact we can have on these patients, I think, obviously, would be huge. But the other real risk to me are these emerging variants. I'm a lot more concerned about them than Scott seemed to be. As we've seen, they've very rapidly taken over elsewhere, even though they're only a few percentage right now. There are reasons, and it not only has to do with fitness, but the ability to evade both natural and vaccine immunity. And thus, they could really significantly undermine the hope of widespread immunity and result in new surges. I mean, already early vaccine data suggests that they may only be about half as effective against some of these variants. I think that, as you said, testing is down, and we've never done a really great job in this country with effective surveillance. But I think if we really committed to effective surveillance as well as targeted deployment, a therapy such as our cocktail that is effective, still retains effectiveness against these emerging variants, could prevent spread of these new variants and could prevent a whole new surge and a whole new recurrence of the tragic situations that we've seen before. And I think that it's really important to really understand and realize that the virus is continuously changing. It's already shown its ability to adapt. It's already shown its emerging ability to avoid effective immune responses. And thus, having therapies such as these antibody cocktails that could withstand these variants and also could be additionally mixed and matched with follow-on antibodies against even more emergent variants, put us in a position where we continue to fight back against this virus as it continues to mutate and evolve itself. So I think these are all really important points. I think that we all hope that widespread immunity takes care of the problem, that this disease really gets into our rearview mirror, but we have to be prepared in case it doesn't, and particularly against the very real possibility that, like they've done elsewhere, these variants can really emerge, can really undermine widespread immunity, whether it's natural immunity or from vaccines, and create a resurrection of this problem. And I think antibodies can be, and right now they're the only potential effective therapy that can really fight back against such a scenario. So I think as a society, we have to be ready for that.
All right, George, thanks very much for those comments. I'd like to next go to Daniel Stovronski. And Daniel, sorry for misidentifying you as David before.
That's okay, no problem. Great, it's a pleasure to be here, and thanks for the invitation, and thanks also, George. You've been such a passionate advocate for the use of monoclonal antibodies, which has been great. At Lilly, we have two antibodies now under emergency use authorization here in the U.S. Bamlanivimab, and then bamlanivimab in combination with etesevimab. The bamlanivimab alone neutralizes the vast majority, the very high 90% of the variants that are around in the U.S. right now, probably close to 99. And the addition of the second one and the combination approach here neutralizes the rest, which is fine, but really it's insurance, as George said, against variants coming to the U.S. that currently aren't here. We've shipped in the United States probably over a million, well over a million doses through the government hospitals and pharmacies. I estimate about a quarter of those have been used, and we've invested a lot in trying to improve usage for patients. It's free to patients, and we'll talk about that, I know, as the day goes on. These products are authorized in about 24 countries around the world, most of the European countries and a few places in the Americas and Asia. And use is increasing in different countries as well. We recently had 2 phase 3 data readouts. I think this is important because, as you said earlier, Mark and Scott also, at first there was sort of not enough data for doctors to make decisions about whether to use these antibodies or not. Now there is. We had 2 randomized controlled phase 3 trials that were successful. The first is in recently diagnosed patients, so sort of a week after symptoms. Average duration here was 4 days from symptoms to infusions, and the primary outcome was deaths or hospitalizations. We reduced that endpoint by 70%, so 70% less hospitalizations. Just think about that for a second, what that could do if this were widely used. The p-value for that was 0.0004. This is a real finding. In a double-blind randomized controlled trial. Death by any cause was a secondary outcome. 500 patients per arm, 10 people died on placebo of COVID-19, a 2% death rate consistent with what we know about this disease. 0 died on therapy. Obviously, that's incredibly important finding. The number needed to treat to reduce a hospitalization is just 20. The number needed to treat to reduce a death is just 50. These are powerful treatments that are now available for patients if they can, navigate the medical system and get a hold of them. And there's plenty of doses out there. As George said, we know how this works. It reduces viral load. Our viral load p-values were just enormously powerful. At 0.001. There's no question about how these things work, and they reduce symptoms. That was also statistically significant. In fact, every primary and secondary was highly stat sig. We also did a second phase 3, which is in the prophylaxis population, testing this like passive immunity as a vaccine would in nursing home residents where there's an outbreak going on in the nursing home. And we just sort of dropped into a nursing home in the midst of an outbreak and started randomizing residents and staff to drug or placebo. And we found among the residents, which was our vulnerable population here that we're targeting, the ones who received the passive immunization, who received this antibody, 80% reduction in risk of symptomatic COVID-19. The p-value there is 0.0002. These are really powerful studies, again, a randomized controlled study, hitting its primary endpoint. And we reduced death due to COVID-19. So not only did we reduce COVID-19 by 80%, the people who got COVID-19 had much lower viral loads, more than 90% lower viral loads, 10x reduction, which probably means they're less contagious, certainly meant they're less symptomatic, and much less likely to die. So in fact, on placebo, out of about 150 residents, 4 died of COVID-19. No one died on treatment. So powerful medicines here for both prophylaxis, which we've applied to the FDA for emergency use authorization, not yet authorized, and treatment, where of course we do have the EUA and are working hard to get the drug out there for patients.
Yeah, thanks both of you for those comments. So we'll come back to the improving evidence, and we'll certainly come back to evidence on how these treatments can be used effectively in practice. It does require some new reforms in care pathways for early stage high risk patients. But right now, I do want to come back to the issue of supply. So as you pointed out, there's a lot of excess supply now for both of your products, with 1 million+ doses delivered, more doses under contract with the federal government for future availability. Just very quickly, do either of you see a challenge in availability for monoclonal antibodies for patients who are likely to benefit, at least those who are at higher risk, as we head out into the future, both with the diminishing surge now, but with the issues related to variant strains, which may need some updating or modifications to the antibodies along the way? Any significant supply issues that you see?
not in the United States. I think the challenge is matching the supply with the patient. So the patient's got to get diagnosed.
Right.
Most doctors still don't know the stuff exists. So then the doctor has to, to know about it. More often the stories I hear are patients asking, the patient knows about it, the doctor doesn't, which is just a huge problem. And then the doctor figuring out where to go get the infusion. The federal government's been good here. Combatcovid.hhs.gov has a lot of information, including a map where you can find out where these products are available. There's the National Infusion Center organization that has a website with the same kind of information.
Yeah, and we're going to cover a lot of that, Dan. So George, from your standpoint, supply adequate, even with the need to potentially modify some of these antibodies along the way?
Well, I think it all depends on the future, and it's been very hard to predict. I mean, if the numbers really continue to go down, then it may be quite possible that we'll be able to deal with the cases that occur. On the other hand, if there are increasing surges, what we already saw, if there are 100,000 people getting infected every day, with many of those being high risk, if that happens again, and particularly it is possible, whether it happens in the fall or whether there's effects of these new very concerning variants to me, then I think that we will need more supply. And particularly this issue, I mean, Dan touched upon it, the United States versus the rest of the world is another very real issue. I mean, there's going to be places where the virus will not be controlled in the near future. So I think we continue to have to think about supply, and I think we should continue to think about having manufacturers maybe consider helping join in or come together, particularly using the most effective treatments against the most concerning variants.
Yeah, I know there have been some federal investments in some additional antibody manufacturing capacity. It takes time to bring online, but a very important point. So Scott, let me go back to you. You painted a bit of a picture about what you think the future is going to look like. Can you say a little bit more, given what we've just discussed, of what policy steps are needed to make sure that the antibodies are available and up to date with the changing nature of the virus?
Yeah, well, thanks, Mark. I just want to sort of clarify. I'm concerned, very concerned about the variants. I think that the issue is, we're aware of them, and we're finally in a position where it feels like we're making the right policy decisions and have the potential to get the upper hand on a virus that has really had us on our heels for since the outset here. With respect to B117, we don't believe, I think George will agree with this, that it pierces prior immunity to a significant degree. And, we have a situation right now, we have 40% probably of the population with some level of protective immunity, either from vaccination or from prior infection. Probably the overlap between the group that's been vaccinated and the group that's been infected is not as much as we think, because a lot of people who've been vaccinated are older individuals who haven't been exposing themselves to the virus, have been actively trying to avoid it. We're vaccinating at least 10% of the population a month, so we're adding to the level of protective immunity. So we have the potential to get ahead of B117 if we can roll out the vaccine more aggressively, which I think the pace is going to pick up. With respect to P1 and B1351, they're more concerning. What's concerning is convergent evolution, where you might see all of these mutations start to evolve into one strain. But we know the vaccines are still protective against P1 and B1351. We've seen probably about a 20% decline in efficacy with the Novavax and J&J vaccine. Probably the mRNA vaccines will be about the same. You're still going to get a good degree of efficacy from the mRNA vaccines based on the experimental evidence that we've seen so far. So the vaccines are still going to be effective, and we have the opportunity now, and all the companies are working on this, on re-engineering the vaccines to come up with consensus strains potentially that could bake in a lot of these variants, so you have a booster available for the fall. I think with respect to your question about the policy, where we need to get the policy right is, I think we need to map out what the regulatory path is going to be right now for trying to get these products onto the market in time for the fall. FDA's talked about licensing a booster vaccine against a new variant on the basis of immunogenicity, demonstrating that you can produce antibody levels that are commensurate with the antibody levels seen in convalescent plasma of people who've recovered from these variant infections. I mean, that's an achievable pathway that would allow you to try to bring something through the development and regulatory process within 6 or 8 months and have it available in time for the fall. We need to make a decision when we're going to switch over manufacturing. Probably needs to happen around July if you want to have supply available for the fall. Question is, do you switch over all your manufacturing if you're a vaccine vaccine developed, or just some of it as a hedge against, these vaccines not working as well, because they'll still be in development. So we need to make decisions around that. And then, George can speak more knowledgeably to the issues around the antibodies and how and when we would make a decision to re-engineer those and how you would convert over manufacturing. But you're probably going to want to see if you can come up with antibodies that are more precisely targeted to conserve parts of the virus that haven't been mutated. Now that we've seen how this virus has evolved, perhaps we can make better decisions about which parts of the protein to target. The virus has mutated parts of the spike protein that we didn't think it would change. And so there's probably things that we could learn from what the virus has done and what it hasn't done that would allow us to design new antibodies as well.
And then in terms of the process of bringing those, sorry, George, I'll go to you in just a second, but in the process of bringing those modified antibodies to market, so maybe some similar steps, and we're seeing some pretty strong class effects here of reductions in viral load leading to the important clinical benefits.
I think that's right. I think you
just described.
Right. We should be in a position where we can rely on the finding of safety and effectiveness from the registration trials and allow antibodies to perhaps come to market through some kind of either an EUA process or an accelerated approval on the basis of the ability to reduce viral load. I think we've now established that the ability to reduce viral load is going to correlate with a clinical benefit here. So, or if we haven't fully established that, that's what we need to establish with some degree of certainty to allow them to come to market, because that's the only way you're going to be able to evolve these antibodies quickly enough to keep ahead of these variants as well.
George, I know you had a final comment. We got to wrap up shortly, but please.
I think that underestimating the concern about variants is very dangerous. I think we have to be clear. While the vaccine data from Johnson & Johnson and from Novavax suggests they're around 90% effective against the conventional strains, against the concerning B1351 and similar variants that have independently evolved elsewhere that all affect the so-called immunodominant epitope, they're only about 50% effective. And to Scott's point, we actually predicted this. There was clearly immunodominant epitopes in the responses previously, and we designed our vaccine prospectively to go to other epitopes, the non-immunodominant epitopes. And I think we have to be very ready. I mean, any sort of, when we rest, the virus is not resting. And I think that the fact that convergent evolution has mirrored the critical mutations seen in South Africa and Brazil, and those have rapidly taken over, they can show us what we should be afraid of can happen very rapidly here. And right now, the concern with decreases in both natural and vaccine immunity against the same immunodominant epitopes requires a need for other approaches. And right now, I really do think we have to, as a nation, be thinking about target deployment to have surveillance and to really find where these variants are emerging and use a therapy such as our antibody cocktail that is still effective against these emerging variants. And if we don't do that, I hope it doesn't come to that, but we could be back in a very serious situation.
I appreciate the point. I do want to emphasize, though, that for the available vaccines, it does look like, at least J&J, what we know about Novavax, more effective in preventing serious complications, 50% perhaps on mild, moderate, but for severe, for hospitalization, still very important effectiveness, which leads to the public health guidance about getting vaccinations in place as rapidly as we can. I want to thank you all for this discussion. Just a quick couple of quick questions that came up. Any worries, George, Dan, about adequacy of meeting the demand for monoclonals for COVID versus monoclonals for many other life-threatening conditions? Have you all been able to ramp up the COVID response while maintaining adequate supply or other products?
Yeah, no threat to the rest of the pipeline for sure, and we safeguard that capacity. I think, as George said, right now there's enough capacity for the monoclonal antibodies, but if things get worse in the United States with new variants, then that could change.
All right. I want to thank you all for joining us this morning. Scott, Dan, George, it's been a great discussion to kick off. A lot more to come related to how we can use monoclonal antibodies effectively to contain the pandemic, both in the short term and for the longer term, including for people for whom vaccines are not effective or they're not vaccinated or they're not able to mount an immune response. And to start that process, I'd like to turn now to Hammy Tourson, who is visiting Senior Policy Fellow overseeing our state partnership programs here at the Duke Margolis Center for some state perspectives on these issues. Hammy?
Thanks, Mark. Great to be with everyone today. So what we're going to talk about for the next 20 minutes or so is really how have the states played a role in helping to improve the allocation and access to antibody treatments. I'm going to provide a quick overview of that piece, and then I'm going to be joined by two experts from the Texas Department of State Health Services, Jennifer Shuford, who's the Chief State Epidemiologist, and Kirk Cole, who's the Senior Advisor to the Commissioner. So we just heard a great discussion about sort of the challenges, et cetera, of what we've been thinking about with monoclonal antibodies. And really just from a state perspective, early on, there were a lot of challenges of getting monoclonal antibodies rolled out and effectively used out in the general public. First, the responsibility fell to state health officials to allocate this drug. It was a time, they're very overwhelmed. There's a lot going on with the COVID-19 response. And so what most states did was really follow the model they used for remdesivir and allocating those antibody treatments to hospitals. At the time, there were, hospitals were overwhelmed. This was an infused drug. There were different pieces you had to do to set this up. And so many were overwhelmed and really didn't take advantage of being able to use the drug because of the additional infrastructure. And I think, as was mentioned in the previous panel, just lack of awareness on the part of providers about the availability of the drug. I would also say, and we probably will hear this from our Texas colleagues, there was skepticism as well in the provider community and among the public about, what is really the effectiveness of this drug, and how can we use this in a way that's easily manageable since it's infused. So where we are today, about 75% of the treatment courses that are allocated to the states remain available. So lots of room to grow. And nationwide, if you look at, the work that's been done in terms of increasing uptake, it's been, it started out at 5%. We're now in some states around 30%. So there's been progress made, but a lot more can be made. So what we did here at Duke Margolis is we spoke to a number of state leaders to hear their perspectives about, what efforts they put in place to try to increase allocation and, looking forward, how they're going to continue on that journey. And I'm just going to quickly go through some of the highlights, but then I really want to turn over to my Texas colleagues to hear more specifically about the Texas experience. So in some of the states that had some success in really increasing the access to monoclonal antibodies, they had leadership, from the governor down to the state health officials, where they really promoted these therapies and communications with the public. They identified champions who could carry the message with different types of providers, like primary care providers in particular, to really explain to the broader patient population about what this drug can do and how it could be effective in really treating COVID-19 early on. I think some of the states that were effective, they also partnered with their state-based provider, nursing home, and hospital associations to increase provider readiness and really gain buy-in. And I think that was the key theme throughout all the different conversations we had, is you had to get that buy-in with a broad group to really, build knowledge and willingness to really work on using this drug. Some of the states dedicated some funding to support provider and health systems to invest in things like regional infusion centers, increasing workforce capacity, and establishing processes to enable prompt referrals. Because one of the challenges, of course, is when someone finds out that they're positive for COVID-19, you have to have a really quick turnaround to get that drug to that patient. There was also some success in centralizing decision-making. Some states set up interagency task forces with appropriate authorities to promote MABs as a treatment option and really make sure that they're really reaching out to all eligible patients in different types of settings. The other piece, which I know the next panel is going to talk about in more detail, is really thinking about where to diversify the infusion sites and increase workforce capacity. So a couple of examples from states is they established regional infusion centers that had broader geographic access to minimize transportation barriers and make sure the MABs were available to a broader group of patients. They did some thinking around alternative settings, so not just hospitals. Hospitals is a great link, but there's also nursing homes, outpatient clinics, FQHCs, really just to broaden the ability to get the MABs out to more people. They enabled screening for high-risk patients at testing sites to quickly identify eligible patients and then have prompt referral systems. They expanded the scope of EMS to provide infusions to homebound settings and long-term care settings to help try to bring the drug to the patient. And they supported efforts to streamline testing to infusion timelines, such as creating a centralized provider referral system and multiple avenues for patients to access MABs in their community. So that's just quick highlights. And now, Jennifer, I'd really like to turn to you to provide your perspectives on the first few months of antibody treatment availability in Texas and what you think other folks should learn from your experience. Jennifer. Oh, there you are. Welcome.
Thanks. Kirk is also joining. We've had our challenges in Texas, and he's been without power for 24 hours, but he's on the phone. So if questions come
Okay.
up. But I'll talk to you primarily about what we've been doing here in Texas and our experience here. So as Amy mentioned, I think when we started off here in Texas allocating this, we knew it was intended initially for acute care hospital settings, inpatient settings, even though the drugs themselves were intended for outpatients, people who weren't hospitalized. And so, but we already had a way to allocate to these acute care settings based on what we had done with remdesivir. And what we had done there is look at a disease burden by county and kind of allocate it by county first, and then look at the facility level to see which hospitals were bearing the burden of caring for these patients. And so we used a similar process. And what that allowed us to do is just gave us a very objective way to equitably distribute this drug. And we were able to push out a lot of information through the Texas Medical Association, the Texas Hospital Association, and through all of COVID-19. We've had really close working relationships with them and almost daily communication with those groups to make sure that we get information out. And we've had stakeholder phone calls. Once these monoclonal antibodies, though, were available for other facility types, we had to adjust our allocation process and incorporate these facilities for which we really had very little insight. We're not the regulatory agency for nursing homes. Our sister agency, Health and Human Services Commission in Texas is. And so we didn't have the same sort of understanding of those facilities. But we knew that nursing homes was where we wanted to target because that was the population. That's the population not only that met all the criteria, but also was bearing this huge burden of disease and death from this pandemic. And so what we did is sent out information to nursing home administrators. We have 3 kind of professional organizations for nursing homes in Texas, and we are familiar with their leadership. And so we're able to get out information through those channels. We also went through their regulatory agency to try to get as complete coverage as we could for all of those sites. And in that letter, what we did is just put a lot of information, basic, important information right up front about what these monoclonal antibodies are, gave them links to the more in-depth information, and put a survey link there and said, if you're interested in providing this to your patients, please fill out this survey. And it gave us point of contact information, their pharmacy license number, those really important things that we needed to start getting them this drug. We also reached out to the National Infusion Center Association, Brian Nyquist, who was a great partner, and allowed us to get this information out to infusion centers over, of course, a holiday weekend, because everything happens over a holiday weekend. Right. And so he was a great partner helping us with that. But even with all of those efforts, really demand was still much less than supply, and we knew that there was more ways that we could use this. And so it prompted some additional activities for us. Our commissioner started to get a lot more involved with getting the information out. He got our governor as well. They promoted it together through the Texas Hospital Association to hospital executives and hospital leadership across the state, just so the information was out there, and his perspective on the importance of these therapies. We also promoted regional infusion centers. And so, you know, Texas it's a crazy landscape. It's so large and so many different populations across our state. And so it really needs to be a local kind of community-based effort. And Lubbock had done a great job of getting their hospitals involved and getting their protocols kind of harmonized, if not totally unified. And so we were able to use what they had done and promote it across the state. El Paso also started their own infusion center as part of a pilot project with Asper. And so they kind of had unfettered supply. And to see how, you know, if it was just kind of a supply thing and if they could really get a lot more usage. But honestly, even these centers had difficulties with getting broader use of monoclonal antibodies for a variety of reasons. And so what we did at that point is that we asked AmerisourceBergen to ship to Texas all of our decline doses, because, you know, we were seeing some decline doses. and stored them in our own pharmacy. So our health department has its own pharmacy. And what we did is kept a supply on hand so that when there were outbreaks, we could immediately deploy those therapeutics across the state, even same day shipping on weekends when FedEx wasn't available. We had state partners that would help deliver that anywhere across the state. And we talked to the Texas Organization for Rural and Community Hospitals. And so that's our hospital association for rural hospitals. And we found fantastic partners there. You know, these rural hospitals have really solid referral patterns within their communities. They frequently have a little extra space where they can do these infusions safely, and even for like infectious patients, which has been a challenge. And so they were able to stand this up fairly quickly and immediately start referring patients in that short period of time that you have to get effective therapy in them. We also worked with our regulatory agency, so HHSC in Texas, for nursing homes they're getting reports about outbreaks in nursing homes. So we asked them to share that with us. And so that when we heard about this, we could link them with a hospital or other facility in their area that already had these therapies and were able to immediately start infusions, either in the hospital itself or transferring the product to the nursing facility. In those settings where there wasn't enough a product or a good hospital partner, DSHS, our public health department, could send out the product immediately to them. And if they didn't even have the local expertise for it, we contracted with teams, medical staffing, to be able to go into the nursing facility, bring the product, bring the equipment, bring the expertise, and be able to start administering those over as many days as we needed to address the ongoing outbreak. And so, you know, interestingly, that there wasn't as much uptake as I expected with that, but it still plugged some gaps. Yeah. And we also just increased resources to regional infusion centers. We helped set up sites, we helped bring in equipment, personnel, and we're seeing a lot more success with these regional infusion centers. I think we learned a lot. We learned that it took some time. It took a lot of time, honestly, to establish protocols, to establish processes. These are not normal processes. Getting product through a state allocation, doing infusions to infectious people in a setting where, you know, either inpatient where it's meant for outpatients or outpatient settings where they're not used to doing infusions. And so setting up those processes have been a huge challenge. And it probably would have been easier if it was kind of more of a normal process, but that wasn't the case. It took facilities and providers a long time to gain trust in the supply. You know, are they going to get a regular allocation? And I think that direct ordering that has now been instituted has helped, knowing that they could get some supply between allocations if needed. And, you know, I think another, unfortunately, reason for our recent success is that our hospitalizations were going crazy. Our healthcare, the new cases, the hospitalizations, the fatalities was incredible here in Texas. And it was stretching our healthcare resources, and people knew they could see the need for these. And we're starting to see a decrease in use. And I don't know if that's possibly because we're seeing a decline in cases and people don't feel as compelled to use these to protect our healthcare system. And so I think that we're just going to redouble our efforts at getting information out there. Physicians need this information again and again. They're not necessarily being able to absorb it all on that first educational push, totally understandably. And so being able to repeatedly get information out to them, I think, is going to be important, as well as us remaining nimble and kind of adjusting to whatever factors pop up. So that's been our experience here in Texas. And I'll pass it back off to you, Hammy.
Yeah, no, thank you, Jennifer. That's fantastic. Just a couple of observations, you know, talking to a couple of other states, they were talking about how, you know, in Michigan, for example, their rural areas were quicker to use the drug than others. And some of that was like the community partnerships have been built, so they could get the word out more effectively. So just really interesting, I think your points about like really having to like build a campaign almost of really education seems to be key. The second piece I also just want to comment on is, you know, so glad to hear you're doubling down efforts. I mean, I think, you know, I've talked to you, I've talked to so many other states about the vaccination effort. It's going to take some time, right? And there's going to be a number of populations at risk. that will not yet be vaccinated. And so, you know, the monoclonal antibodies is just another tool in your arsenal of really trying to help folks. And so just curious, I might just ask one question, then we should switch to the next panel. As you kind of push on that vaccination effort as a state, you know, you're going to double down. Do you see any particular challenges in like educating the public? You know, you should still get tested. You should still be able to have access to treatment. Kind of, are there any things you're looking at future for the next couple of months on monoclonal antibodies specifically?
We are, you know, I think that a lot of our major population centers do have these regional infusion centers, but we don't have that centralized place for people to get information, either the population to get information about the importance of these or physicians to get information about how to refer patients. And so we are working on gathering that information and making it available widely so that the people who are being affected and the physicians clearly understand the importance of the quick diagnostics, the quick treatments, as well as how to do it in their own community. And that's been actually a major issue, just getting the information about the referral process out there. And so we'll be working on that over the next month.
Great. Well, thank you so much for sharing your perspectives from Texas. More to come. I'm going to now turn over to my colleague, Marta Wazinska, who's the Deputy Director for Policy at Duke Margolis. Marta.
Thank you, Amy, so much. What we're going to do in this panel is to talk to some of the participants in the healthcare system and who have been on these drugs in a timely manner, because again, what is really critical is getting this drug to patients early. And as Jennifer mentioned, the initial allocation really followed what we have been referring to as the remdesivir model, which was a drug that was used in hospitalized patients. And this drug is intended really for patients who are outpatients early on in their disease state when they're not interacting with the healthcare system. And that clearly required that to really turn around the process upside down. So what we're going to begin with is a discussion with someone in an integrated healthcare system to talk about how they've been able to adapt, but then to highlight the fact some other perspectives from players outside of the health systems, integrated health systems, because many high-risk patients are actually outside of the integrated health systems, be it in long-term care or patients who don't have insurance or are underinsured, and you might use the federally qualified health centers, as well as patients that have a hard time accessing infusion sites because of transportation or just being homebound for other reasons. So let me introduce the panel. We will begin with Brandon Webb, who is the Associate Professor, Division of Infectious Diseases and Clinical Epidemiology at Intermountain Healthcare in Utah. He's also the Chair of Intermountain COVID-19 Therapeutics Committee and Medical Director for Intermountain Monoclonal Antibody Program. He is also the member of Utah Crisis Standards of Care Scarce Medication Committee, which is one of those bodies that Amy highlighted, where states have set up these kinds of committees to help allocate the scarce resources and set standards for how the drug should be used. Then we'll turn to Christian Ramers, who is an infectious disease physician, Chief of Population Health at Family Health Centers of San Diego. He co-moderates a web-based mini-series on monoclonal antibodies supported by HHS ASPR and Project ECHO. We will then turn to Christopher Laxton. Chris is an executive director of AMDA, which is the Society for Post-Acute and Long-Term Care Medicine. He serves as chair of the Advancing Excellence in Long-Term Care Collaborative, and he's also a treasurer of the Center for Excellence in Assisted Living. And he represents AMDA on several national coalitions, including the Leadership Council. His organization is partnering with the American Society of Consultant Pharmacists to stand up one arm of the Special Projects for Equitable and Efficient Distribution, which stands as SPEED for short, of the COVID-19 outpatient therapeutics. And he'll talk about his involvement there. Then we will turn to Bill Bolgar. who is the Senior Director of Pharmacy Innovation at Quorum, which is a CVS specialty infusion company. He's a member of the Quorum strategy team, where he identifies and develops strategies to improve clinical quality and patient outcomes. And he's one of the project leads at Quorum for the bamlanivimab pilot. And last but not least, we have Morty Searle. He is actually a trust and estate attorney, so very different background, but he co-founded a grassroots volunteer organization back in March 2020 called the COVID Plasma Initiative. And as the name suggests, CPI was set up to support convalescent plasma treatment, but has now turned to support access to the synthetic monoclonal antibody treatments we're discussing today. And the organization has facilitated infusions to over 4,000 COVID patients. So with that, if I could turn to Brandon for a few minutes of remarks.
Thank you, Marta, and I am looking forward to hearing from the other panelists as well. I just wanted to share a few thoughts with respect to our experience in an integrated healthcare system that spans a geographic footprint of more than 400 miles and a population of more than 2.5 million. I think to our colleagues in Texas' point, it was very clear right from the outset that delivering an intravenous infusion to actively contagious patients in an ambulatory setting that overlaps with other care populations that require maintenance of their access to care is no small task. And it is an investment. But I think as the evidence continues to accumulate, it becomes more and more clear that this is a worthwhile investment. And the principles of access and equity remain at the forefront. I just wanted to touch on sort of one guiding principle that's really been instructive for us, and that is to creatively leverage the resources you do have to be able to provide as many infusions as possible. In our position, the first thing we did was actually identify a geographic distribution strategy. We asked ourselves, how can we get drug to as many qualifying individuals as possible in as an efficient way as possible? And for us, what made most sense was to actually combine the strengths of the infusion center venues with the geographic footprint of the urgent care facilities in our network. And that was a quick win. And it allowed us to stand up 17 infusion sites that spanned this 400-mile, 2.5 million person range very well. Other systems have found that leveraging emergency departments is also a very effective way to do this. And others have found that setting up centralized treatment centers in existing clinical locations are also effective means. The other thing that is key here is identifying and streamlining an early patient identification method. And for us, what worked very well was to leverage the reporting of test notification at the time of test positivity reporting to identify patients as early or as soon after their diagnosis as possible, and then to proactively reach out to those patients. And to date, that's been very successful for us. We have approximately 48-hour time from test to monoclonal antibody infusion by really seeking out actively to find those patients at the point of test. And I know that there are other centers that are following a similar proactive patient selection strategy, as well as others who have stood up a standing order pathway, which really streamlines that as well. So just to follow up in summary, I think there's no one size fits all, but for healthcare delivery systems, I would say this is an investment worth making. And I think we all have resources that we can bring to bear if we think creatively. Back to you, Marta.
Thank you so much, Brandon. If I could turn to you, Christian, next.
Sure. Thank you, Marta, and thanks, Mark, for hosting this important session. I do have a couple of slides to help illustrate my points. While we're bringing those up, I'll just say that Family Health Centers is a federally qualified health center network consisting of 23 clinics in San Diego, really in our hardest hit neighborhoods. And I think the slides just help visually show the issue of equity. So if we could go to the next slide, Anna, and then the next one as well. So I think in all of your cities and regions, you've seen the disproportionate impact of COVID-19 on people of color. In San Diego, this is illustrated with these two graphs here showing an incredible gradient from the Mexico border all the way to the north, which really falls along socioeconomic and racial lines here. On the left-hand side are cumulative cases as of mid-December, and then on the right-hand side, just a snapshot of 2 weeks in December. And you see an obvious and persistent geographic disparity of COVID-19 cases really along racial and sociodemographic characteristics. To the question of why we would involve FQHCs in allowing access to this innovative therapy that could potentially save lives, well, if you've been paying attention, you've seen these obvious disparities in your own neighborhoods. And really, the model of providing monoclonals only in tertiary academic centers or large hospitals doesn't reach far enough into the neighborhoods where patients are most affected. We go to the next slide, please. So this is just some data from San Diego showing that although Latinos comprise about 33% of the population, they have comprised 57% of COVID-19 cases, 57.4% of hospitalizations, and 48% of COVID deaths. This is essentially the definition of a stark health disparity. And if we don't have a strategy to implement our interventions to address these disparities, we're really just going to perpetuate more of this. Next slide, please. So this is my last slide. I just want to show a couple of graphs. Again, you see the gradation from these social vulnerability index from the CDC. There's another similar social determinants of health index called the California Healthy Places Index. And clearly in the darkest blue, these are the communities that are most heavily impacted with socioeconomic, low socioeconomic status. But on the far right, you can see the original distribution points for monoclonal antibodies, which is along the same lines of the remdesivir allocation. And you can see these hospitals that really received these were clustered in the north, in La Jolla, in Del Mar, getting up close to Orange County, which are clearly not the communities that were most heavily hit by COVID-19. So just in conclusion, I'll say that involving FQHCs is really part of the solution if we're going to address these equity problems and these health disparities. And if we want to move the needle at all on some of these profound health disparities in infection, in hospitalization, and in deaths, we really need to involve the communities themselves. And community clinics and FQHCs are well positioned to do this. Thank you for your time.
Thank you so much, Christian. I will definitely come back when we are having a full discussion to have you talk about how your FQHC has gotten involved, but we'll come back to that. So if I could next turn to Chris Laxton.
Yep, thanks, Marta, and thanks to all of you for this important session. Just a few comments about the post-acute long-term care world. We have my society, the Society for Post-Acute Long-Term Care Medicine, has always been very supportive of the potential for monoclonal antibodies, but initially reluctant, really for two reasons. One, we had not seen data yet. We now have on our population, which is the frail elderly. Nor were we concerned, well, rather we were concerned that there were staff constraints around infusing in the setting. However, certainly in the first case, the therapy has become and it's continued to be a very important tool to prevent disease progression and hospitalization in the nursing home. Somewhere around 30,000 doses have been distributed through the SPEED program and other methods. And about a third of those, I'd say, have already been infused within our patient population. It appears to be extremely well tolerated. Our doctors are telling us there are a very small number of adverse side effects and really no reports from the field of anaphylaxis. This is actually better than the trials initially reported, so very pleased. There's a question about why the therapy has to be infused in the skilled nursing facility or the nursing home. It really has to do with the nature of the patient population. Firstly, we've got a frail elderly population. They are immunocompromised largely. Some 70% live with some form of cognitive decline all the way up to full dementia. It's very challenging to transport these patients, and they also represent a transmission risk. But secondly, nursing home staff are stretched beyond the breaking point and are really not able to provide transportation services. So those have to be brought in from outside. And when you get into the many, many nursing homes that are in rural settings and underserved geographic populations, it becomes even more difficult. as Marta said, we've been involved with the SPEED program. We partnered with the American Society of Consultant Pharmacists, ASCAP, to do two things. Firstly, raise awareness of the availability of MABs in the SPEED program, and actually through other means as well. ASCAP's role was to connect their consultant pharmacist members with HHS in order to get doses. Our role was to raise visibility among our chapters through our members directly, and also through our network of nursing home CMOs in order to make them aware that the program is available and that they could connect with their consultant pharmacists to distribute them. We also produced a readiness packet, which I think y'all are aware of. It's going to be cited in the Duke-Margolis paper that really has kind of soup to nuts approach to how monoclonal antibodies should be approached in the nursing home population. Really, the way it works is nursing homes would reach out to their consultant pharmacy. If they're not enrolled, they can enroll. The pharmacy orders the number of doses needed for their facility through SPEED, and HHS ships the product directly to the clinical staff. Medication is free. There is reimbursement of $313 for the administration of the therapy. In terms of pointers on how nursing homes might make the most of this program, I think the first step is to consult with the consultant pharmacists, partner up with them. If they're a large provider like Quorum, which we'll hear from next, they obviously have a infusion service. If staff are able to hang IVs and administer the therapy and monitor it, obviously that's the simplest approach. If not, though, a home infusion provider, a local hospital infusion service may be able to come in, especially if they're part of a large health system, which a number of nursing homes are. I think for that, Marta, I'll stop and you can proceed to the next panelist.
Great, thank you so much, Chris. So yes, great segue to Bill Bolgar, who represents Quorum and can talk about the Quorum pilot that had been rolled out. So Bill.
Thank you, Marta. So just to give you a little bit of an overview of our pilot, we've administered about 1,300 doses in our 7 pilot markets, which are Chicago, Milwaukee, Minneapolis, Los Angeles, Boston, Tampa. I think I got them all. And our focus was really on providing home infusion and support to patients in skilled nursing facilities. And so, as we kind of started our project, one of the things that we were preparing for was this tremendous onslaught of volume once the EUA was approved and our pilot began. And what we found out was exactly the opposite. We thought it was a build it and they will come proposition. And so we were concerned that the volume was going to, literally overwhelm us once the pilot program started and the word was out that we had product available and we're providing the service. And, what we found is that there was a huge lift on our part with regard to education in the prescribing community on how to use these products. Many of the prescribers, for these monoclonal antibodies are not physicians who are used to writing for MABs and were not necessarily familiar with how home infusion worked. And so as we, set up our model, we, determined very quickly that, we had to deploy resources in order to address this. And so we stood up a call center to, manage all of the phone calls from, inquiries about, how to prescribe, who qualifies, as opposed to and educating the different physicians. We had to work with physicians from many of the different health systems. We worked with physicians from skilled nursing facilities, and had to flex our model to work with them on how they could get us referral information, the clinical information to evaluate patients who qualified. And so what we thought in the beginning was we would just be the service provider providing home infusion. We ended up having to make some significant investments in infrastructure from the call center and staffing standpoint, as well as educational resources for the prescribers. Then with regard to this, I think Christopher touched on some of the benefits of the program, in that we can take the care to the patient. So we address issues of transportation. We address issues, with both for patients in the home and skilled nursing facilities, but we also, support the skilled nursing facilities with regard to, bringing that infusion skill to them, as well as we know that, nursing resources and staffing, across the healthcare setting are tight. So it gives us the ability to come in, manage these patients for a couple of hours and, allow them to remain in their care setting. So it's been, very successful from our standpoint. I think, the challenges that, that we've had is really just, is scaling for volume. And, we've seen markets, from our pilot markets where, in Milwaukee, there was very little utilization or adoption. And then you look at what we saw in Los Angeles and Boston, where, the demand, was through the roof. And so we had to, move nursing resources and clinical resources around to meet that demand. And all the while we were doing this, we were focusing in on, reducing the length of time between notification of a patient needing infusion and actually getting our nurses out there. And we were able to reduce that from, 3 days at the beginning down to just a little over a day recently. So, we're very pleased with our results here. We're also thankful that, HHS did provide us some additional reimbursement to provide these services to these patients as part of our pilot project. And, I know that, that Connie Sullivan from NHA is going to talk about, home infusion reimbursement. But I just want to add, that there were, many, Connie will cover many of the issues and how we manage home infusion. But I just wanted to share, some of those additional things around generating demand and call centers that, kind of fall outside of what you think of in typical reimbursement for home infusion services. So thank you, Marta. I appreciate the opportunity today.
Thank you so much, Bill. So both Chris and Bill and Connie, whom Bill mentioned, represent a segment of how you reach out to the patient and bring the infusion to the patient. And a lot of work with long-term care, but also, as Bill suggested, some is actually going to the patient's home, but a lot of it has been the long-term care. And there's, as Bill mentioned, there's a lot of education that needs to be part of this outreach, because again, you need to catch these patients early in the disease state, and providers, prescribers need to be ready to engage the patients. And so actually, this is great to have Morty Searle come in and talk about a very different approach for how to get patients early, maybe even before they test. It's when they might actually are reaching out to high-risk patients. So Morty, if you could talk a little bit about the COVID Plasma Initiative and how you have engaged and how you've been expanding.
Sure, Martha. Thank you for having me. It's an honor to be on this panel, an honor to be part of this webinar representing COVID Plasma Initiative. So let me give a little bit of an introduction about COVID Plasma Initiative. Some of you may be wondering, what is COVID Plasma Initiative doing on a monoclonal webinar? Did I get the wrong invitation? I'll give it a little bit of a 30-second background. We were formed in March 2020. Myself and Webb as the co-founders. It's a grassroots, totally volunteer-based, we're not healthcare provider organization based in the Jewish Orthodox community. We formed under partnership and guidance from Mount Sinai Medical Centers in New York City. Dr. Bander, Dr. Shatkus, Dr. Aberg, and Dr. Reich have given us tremendous support all throughout and guidance. So we were tasked with initially collecting plasma. Our communities had been hit early in March, and we had therefore the first recovered patients. They reached out to us and we started recruiting donors, and then it just went from there to doing anything to further the plasma treatment. Talking to blood centers, working on procedures, setting up conference calls between EAP data and local hospitals. And it rolled out nationally, that the organization, the effort, and to where it is today, where the majority of COVID patients in America who are admitted to the hospital receive plasma. One thing we learned throughout that whole journey, which we've leveraged, besides for all the relationships and tools and credibility, is that treat early, treat wisely. That the key to successful plasma treatment we were seeing in patients we were sending in was that we needed to have early treatment of plasma, preferably. At that point, the emergency use authorization, and as of now for plasma, is only upon hospitalization, but it should be immediate, not within the first couple of hours, and wisely with high titer plasma. And because of that, we started tracking and had our eye on the Regeneron and Eli Lilly monoclonal antibody product. Why? Because that was a perfect extension and amplification of treat early, treat wisely. It was aimed at the outpatient population and it was sort of, this is a metaphor as a sniper rifle, the powerfulness of the monoclonal compared to plasma. So treat early, treat wisely. We were tracking it. We were sending patients in to the Regeneron randomized control trials that Mount Sinai was running, and we were very, very impressed with the results that were happening. So as soon as the emergency use authorization was issued for the Eli Lilly product in the beginning of November, and subsequently the Regeneron product, we made an internal policy decision in COVID Plasma Initiative to sort of focus as much efforts as we can on furthering this treatment in the community. And we formed what we call our MAB squad, MAB, Monoclonal Antibody Squad, and we put together a core group of volunteers. And we focused on our goal, our ideal for the treatment model was that somebody would wake up in the morning, they're symptomatic, they have a symptom of COVID, they would run to get a test. If that test is positive, a rapid or PCR, whenever it comes back, go in to a treatment site. And by the time they go to sleep that night, they know that they took care of getting their monoclonal treatment, and they lowered their risk of hospitalization and death to below 99% and even better for death. Now, in order to be able to do that, we determined that we needed to have 3 steps involved, and this was the model that we set up, and we set this up with the intent that it could be brought to other communities as well. And the goal again is to get from first symptom to treatment within 24 at the outlier for 48 hours from first symptom to treatment. And we did that by number 1, we needed to get the word out to the community. We needed to spread the word. Why? Because people have to know about this before they're sick. People have to know about the monoclonal antibody treatment. They have to know its effectiveness. They have to know its availability before they have a symptom. Why? Because like I said, when they wake up in the morning and they know they may have been exposed and they have a symptom of COVID, they have to know, I have to go right away for a test, not say, you know what, let me see what happens, let me wait, because we know monoclonals work, treat early, you got to treat it early. So we put out a huge education campaign. I'll speak about the specifics, but let me get to the other 2 steps to our model. The second step is that we as an organization had to accumulate and compile information on where the community could get treatments, where the treatment was available, what specific details a person needed to know as to expectations. For example, what qualifications did a site need? Was it a PCR, a rapid? The EUA allowed for 10 days from symptoms. Some places were more stringent. And what was the definitions? You know, what's considered immunocompromised to a specific site? So we accumulated, compiled, reached out to infusion centers and compiled all that information. The third step, it was to get that information to people who are seeking treatment. Make sure that the people who now know about monoclonals, who tested positive, who want to get their treatment, can be able to get this information, set their expectations correctly in order to get the treatment. And we found that if people have clear instructions, clear expectations, know exactly what's going to happen, that will get you very good saturation and very low drop-off rate from people seeking treatment to actually getting it. So let me go a little bit further into those 3 steps. Getting the word out. Getting the word out was the first one, hospital outreach, or infusion center outreach, and then be able to connect the patients to the information. So in terms of getting the word out, what we did was we set up webinars in the community with Mount Sinai. We reached out to doctors. We set our website to doctors to spread the word, primarily community physicians, primary care, and we asked them to please get out the word. The Blaze 2 trial was very persuasive at that time. We asked community leaders, rabbis, other community leaders to tell their constituents, tell their congregants about this information. We launched a very large advertising campaign in community publications, internet, social media. We made ambassadors to please reach out to the community, and we put up billboards throughout our areas. And maybe perhaps the most powerful method was, as data was coming in as to the results, the first couple of weeks, as we were sending people, high-risk people that qualified for the treatments, and they were coming back, and we saw our hospitalization rate decline to the extent that now today, really almost all patients that are getting to the hospital are people who didn't qualify for antibody treatment, who weren't able to access monoclonal antibodies, which means that our knowledge saturation in the community is incredibly high, and people know about it, people are seeking it, people are getting it, and when they get it, it's effective for keeping them out of the hospital. And as that data got out, it just grew and snowballed and snowballed and snowballed, and more people knew about it and requested it. The second step, accumulating specific information as to where people can get the treatment. So we set up a hospital liaison, infusion site liaison. We set up a site locator on our website, which was very easy to access for the broader community. And finally, and I'll end with this, the third step, in order to connect patients to the information. So we set up probably the most powerful part of this was our hotline. We have a 24-hour, 7-day-a-week hotline where it's answered. People seeking treatment can call in, discuss their qualification, if they qualify, discuss where to go, which site works best for them. And I think so far we've handled over 1,000 calls directly on that hotline. And with that, I'll hand it back over to you, Martha. Thank you.
Thank you so much, Morty. So we have about 10 minutes that were for more follow-up. So actually, let me ask you one follow-up question, Morty. So I understand that the model has been very successful. You started off with the Orthodox Jewish community in New York City, but you have expanded to the outreach to the Hispanic community, not only in New York City, but outside. Can you talk briefly? Is it your organization that is doing it, or are you partnering with other organizations, grassroots or community organizations to do that?
Yes, our organization, COVID Plasma Initiative, primarily my co-founder, Chaim Leibowitz, we've done outreach to some of our other communities that we've connected to through plasma. And primarily, the one example of that is the Latino community in Southern Texas. And really what it is taking these 3 steps, leveraging the ability of a community organization to reach people before they're sick, to them to know about it, give them clear instructions on where to get treatment, and then keep putting out the word, include positive data as it comes in. And we're very proud, and that was part of our mandate from the beginning, was that whatever model we grow, make sure that it's sort of like a keystone type of model, that it's translatable into other communities.
Thank you so much, Morty. And for those of you who are listening in, if you look at the paper that we issued this morning, you'll see some examples of some of the creative ways in which this organization partnered with others, including, for example, engaging pro bono, a marketing firm in Texas, who then did a big campaign with TV spots and news stories. So let me now turn back to you, Christian. So Christian, you made a very compelling case about why FQHCs need to have access to this drug. Can you talk both about how FQHCs are getting access to this product, and also what are your recommendations for how they could be streamlining the process, given the complexities, for example, with transportation that patients might have?
Sure. Well, early on, the distribution really followed the same lines of the remdesivir distribution, which was mainly to large hospitals and health centers. And we actually had to fight for doses from our county, since they were going to the bigger hospitals, which in large cases were not using a lot of the doses. They were sitting in their fridges. So we had to sort of make some noise. But thankfully, at the federal level, the SPEED program was developed, which I think a couple of you have alluded to, where allocations can be directly given to any center, really, whether it be urgent care, long-term care facilities, or federally qualified health centers that have the ability to use them. So I think things have been a little bit more targeted now with distribution. So we've actually gotten doses from both mechanisms, so through the county as well as through SPEED. And then in terms of getting patients to where they can receive the drug, this is just it's like the Willie Sutton principle. Why do you rob banks? Because that's where the money is. Why would you infuse monoclonal antibodies in community clinics? Because that's where the patients are. And Morty, hats off to you for the marketing that's been done, but we don't have to market to communities where we've been there for 50 years and there's a deep trust that you say you can come to your regular community clinic in your community to receive this. There's no marketing, and marketing is difficult to cut through a lot of the mistrust that comes from these communities of color. When it's me calling in Spanish saying I am from Family Health Centers of San Diego, there's an immediate trust and familiarity with what we have to offer. So transportation is not that much of an issue when we don't have to move patients out of their own community. We have two centers, one that's very close to the border right now in Chula Vista, and one that's up in Hillcrest closer to downtown. And invariably, when we call patients, where do they want to be infused, they are saying closer to their neighborhood down in Chula Vista. So it's actually a much busier center for us. And it's not that complicated of a concept that you bring the therapies to the communities where COVID-19 is so epidemic.
So, and this is a general question, and I don't know which of the panelists would like to take it. In terms of trust and understanding of really when this treatment makes sense, there are a number of patients who seem to be concerned that if they receive this treatment, that they will not be eligible for a vaccine. Can anybody on this panel speak to that?
It's Chris. I can start. Others, I'm sure, can weigh in. We've heard from CDC and tested this in our own population that the monoclonals can be infused even in between doses of the vaccine if that's called for. But CDC has basically said if you wait 90 days post infusion, you then become eligible again for the vaccine. So this should not be a concern for folks that they can't be infused if in fact they have COVID symptoms, and the alternative would be hospitalization, which is obviously not what we want.
Brandon, you went off mute, so I'm wondering if you would like to chime in.
Yeah, just briefly, we end up having a lot of those conversations with patients. And I think one of the, again, guiding principles there is that these are high-risk patients who are poised to not do well with the COVID-19 that they do have right now. And so we usually just frame the conversation such that they understand that treating the disease that is at their doorstep currently is a better investment than deferring so they can be vaccinated to prevent some future second infection. And I think that goes over well with patients. And then we reiterate that our current understanding is that natural immunity very likely extends 3 months or more. And the monoclonal, the half-life is such that it'll still be circulating for the next couple of months. So they can be confident that they can be well protected from an immunity standpoint during that window period until they are eligible for vaccination.
Yes, and you already have the disease, right? So Chris, a quick follow-up question to you. So there was a discussion early on around vaccinations being rolled out. Nursing homes were the priority group. So how do you see this therapy moving forward, given that this is the population that has had so far the largest access to this? Do you see this being less of a player, or like what role will this therapy play in long-term care settings moving forward?
Thanks, Marta. It's a good question. Nursing homes are not static environments. Even though people stay there generally for 12 to 18 months, there is turnover both in the short stay population as well as the long-term care population. And so new patients will come into the setting. They may come in from community settings where they have exposure. They will need to have access to the therapy going forward. So we continue to see this as a very important tool in our fight against COVID. If for no other reason than to continue to reduce the pressure on overwhelmed emergency rooms that are now continue, even though we see cases dropping, thankfully, there's still a great deal of pressure on hospital environments and emergency rooms. So if we can keep more people out, as well as obviously improve their quality of life by stopping or slowing the disease progression, very important to do. And we continue to be concerned that even though a large percentage of the nursing home population has been vaccinated, staff have had less confidence in the vaccine process. And so we will need to continue to have access post the federal partnership to vaccines for both the staff and the residents. So until we have a clear decision that we've got good population-wide immunity, we need all the tools in our armamentarium. And so the MAB is an important one. Obviously, the vaccine is going to be very important as well.
Thank you so much, Chris. So we could have probably discussed this for another half an hour easily. There's so much to cover. There's so many ways in which one could advance utilization of these drugs and make sure that we have equitable access to this product. I would like to again refer you to the paper that we issued this morning. It has a lot of resources in it. It has some resources for FQHCs. It has examples of educational materials that have been put forward, a lot of examples of how processes have been streamlined. It has links to some of the locators, for example, the NICA locator for where monoclonal antibody treatments are available. We have links to all of this. So I recommend you have a look if you're looking for ideas for how to improve the process and to create more equitable access to the product. So with that, I would like to thank all the participants and panelists and turn it over to Mark.
My thanks to you, Marta, and our panelists as well for that review of where we are in terms of effective ways to provide timely access to antibody treatments for patients who need it, particularly those who may be hard to reach, like patients in communities with limited access and patients who are fragile and unable to easily reach an infusion center. As we also note in the Duke Margolis report that was released today, though, there are still some challenges ahead for effective antibody use. And to help us talk about these issues going forward, I'm very pleased to be joined by Dr. Rob Califf, who's former FDA commissioner, now head of clinical policy and strategy at Verily Life Sciences, working at Google as well. Connie Sullivan, who's president and CEO of the National Home Infusion Association, and representing our colleagues and all of the team at the federal government working on these issues, Meredith Chuck, who's from FDA, but currently detailed to focus on the COVID response effort at HHS, particularly related to monoclonal antibody therapy. So Rob, I'd like to start with you. We've talked some about the evidence issues, how they've improved, some of the challenges along the way. I know this is something you've thought about a lot, including planning for variant strains. Any comments that you'd like to highlight to kick off this discussion?
Yeah, thanks, Mark. It's been a great discussion and some tremendous examples. I'm going to go quickly here because I know we're short on time, but I feel compelled to say a few words about what's already been said and putting that in some perspective. There were two elements that are normally part of diffusing a treatment into practice that we didn't talk about at all. Number one, under an EUA, the manufacturer can't promote the product. And a large part of my career has been trying to get rid of the need for pharmaceutical sales reps, for example. But the fact is, that's the way most products get diffused into practice, because those people are driven to do the kind of things that you've been discussing here. And I just feel like people need to think about what this means. The second is clinical practice guidelines. And because a lot of this evidence has not been published in peer-reviewed journals, You know, the NIH website still says not recommended as standard of care. And, you know, I've seen enough of this data to be convinced. I feel like we're in the early days of heart attack treatment where you have a life-saving treatment that's not being used the way it should. But I would really urge the manufacturers to get their results published in peer-reviewed journals so that the guidelines committees can meet their standards. And I think for the future, we ought to think about policies for pandemics about how to deal with this very rapid turnaround of data and how to deal with it. So just because FDA issues an EUA doesn't mean that the professional society is going to buy into it. And they've become a bit jaded by all of the false claims that have been made, not so much by manufacturers, but by other so-called experts using shabby data to make claims that are not correct. So those are two underlying things I think we need to really work on and try to fix. But for the future, I think there is a picture of what could really work. A network of the kinds of people that have already been on this call in a system that's collecting data, which is really going to be needed, because if we envision this period where we have these mutations causing variants, I completely agree with what Scott said, that it's likely the FDA will move to viral load for antibodies as being the requirement for approval, just like we have for HIV drugs and hepatitis C now, because I think the evidence is strong enough. But of course, the FDA will have to look at this independently and make that judgment. But if they do that, we're going to need to be able to rapidly test these new cocktails that come out in response to the variants and prove whether they actually do have similar efficacy. And then we're going to need a post-market system that can collect data that's very reliable in a rapidly shifting evidence environment. So I hope we will evolve to such a system in the near future, because I believe that's what we're really going to need in this new part of the pandemic that we're coming into.
Yeah, thanks, Rob. And just a quick follow-up, I think you helped us write a paper recently reviewing the state of the evidence, which does now include some published studies, New England Journal and the like. Your sense of where the evidence stands now, and any particular ways to accelerate that publication, that peer review and publication process? We are in the midst of a pandemic.
I don't know if George is still on, but I just want to say we have Med Archives now. So if the data are compiled, they can be stuck right in Med Archives immediately. It doesn't jeopardize future publications. Then it's there for people to see and comment and think on. And I think particularly Regeneron has some spectacular data that's coming out in press releases that I hope will, because the guidelines committees just can't set aside the standards. Otherwise, they'll have all these other fly-by-night people that they'll have to spend all their time dealing with.
Thank you. And I want to go to Connie now. We're going to switch gears a little bit and talk about some of the issues around home infusion. So we've heard about some programs that are doing it, assisting nursing homes, assisting areas with outbreaks. Texas has set up some programs to provide on-site infusions in areas that might otherwise be hard to reach. Connie, can you say a little bit more about, I know there's some reimbursement challenges and issues, but some of the promising steps or pilots that you've seen to address it. We've talked a little bit about the Quorum pilot, for example. I think you all have some other ideas too.
Sure, yes. Thank you for inviting me to the discussion today. NHIA is currently also involved in the SPEED program, enrolling home infusion providers to help deliver monoclonal antibodies to patients in long-term care and other high-risk settings, and we've been very successful in that. We've reached about 400 patients in 80 different facilities nationwide. We have product in the hands of about 170 plus home infusion providers, and the uptake has been strongest in some of the smaller communities where they are underserved and have less access to some sort of centralized infusion center. But what we haven't been successful with so far is expanding home infusion more broadly to some of these rural markets. And I think we can't underestimate the challenges that transportation plays in some cases to getting to these centers. Some patients in rural areas just don't have good options available to them. So one of the things that we've done at NHI is try to collect some data around what the barriers are to expanding home infusion more broadly. And quite honestly, it really comes down to inadequate reimbursement. The cost for home infusion is significantly higher than what the Medicare payment allows. And unfortunately, a lot of commercial payers either haven't added a fee for administering COVID monoclonal antibodies to the fee schedule for home infusion, or they have adopted the Medicare allowable rate, which may or may not be negotiable. Just to give you some insight as to the cost of home infusion and what's wrapped up in providing this therapy at home, we're estimating best case scenario, we're talking about $580 some on average for providing this service. And that, what I also would like to say is that with home infusion, the first visit is always the most expensive to provide, because there is an extensive onboarding process. And what Bill alluded to earlier with the CVS pilot is very true. You are having to walk everyone through that process, and it takes a lot of time. And you have to do a lot of preparation with the family before the nurse comes out to the home to make sure things go smoothly. But in addition to the onboarding process, there's also additional supplies that are needed. It's not uncommon to see pharmacies driving product several hours into rural communities to get it there for the nurse. And then nursing costs vary from market to market. Obviously, there are different rates in Southern California than there are in some other rural markets. So the costs do vary, but we feel confident that if we can address this insufficient rate and try to get the rate up a little bit higher, that we could enroll a lot more home infusion providers to serve patients in rural communities. The one other thing I wanted to just mention is that we've talked about process and is there an easy way to stand up an additional payment model under Medicare? We do think that there could be a fairly simple additional code provided for either an add-on payment or a higher rate when the product is administered in the home. And there are precedents with the DME POS program for identifying eligible and capable providers, as well as a definition for home that would include high-risk settings such as assisted living facilities, group homes, homeless shelters, and substance abuse facilities. So I would just add that, while we do have a situation where our case counts are a little bit lower, I would hope that we can work on resolving the access issues for home infusion, because we could use this time to do that outreach and education that's needed to make these therapies more available. Thank you.
Thanks, Connie, for that concise overview. If I could just follow up. So you gave one suggestion of a payment modification that might work in Medicare for these patients at home who just can't get to infusion facilities, but are still high risk and would benefit from treatment potentially. Are there any commercial Medicare Advantage, other payers who have taken steps like that, or any pilot programs working with states or others that have helped fill in some of the gaps?
Medicare Advantage, I believe, is billed through the same vaccine program to Medicare. And so I don't believe that there are options, even when Medicare Advantage is running through a commercial payer, to get a higher rate. I hear from providers that it's kind of hit or miss. You have to call every payer and find out what rate you can negotiate. So I'm not hearing that there's been a consistent model set up. I think maybe there's one program I'm aware of with Optum and United Healthcare where they're running some sort of pilot for their membership, but nothing that's widely available across the country.
And that one, I think, does involve a little bit of additional payments, and in an integrated system like that, they, I think, can see some of the financial as well as the health benefits of preventing the downstream hospitalizations and other complications, which, also, as we discussed in the report, is maybe a useful framework for thinking about further steps in this area. But thank you very much for the comments. And now I'd like to go to Meredith Chuck. Meredith, you're living monoclonal antibody development, evidence, response every day. You've heard a lot today from a range of your partners in using monoclonal antibodies effectively: healthcare providers, infusion providers, community clinics, health systems, nursing facilities, states. Any comments that you'd like to focus on for the challenges going forward and how to respond to them?
No, thanks very much. And I think one comment that I have overall is that it's been really encouraging to hear about the number of best practices and a number of different care models, because as was mentioned, a number of times, this is a complicated outpatient administration process. So it really is going to take a number of different care settings. And each of those care settings has particular challenges that need to be addressed. So really bringing groups like this together to be able to share best practices and avail them widely is really what it's going to take to move things forward. So appreciate the opportunity and appreciate Duke Margolis's efforts in this area. I think one of the key things, and then part of what I'm going to reflect on a little bit what Rob talked about, is the data collection. I think that's a really key in terms of trying to get additional real world use and evidence for this therapy. The clinical trial data is certainly improving, and we all love to see those results, but we have hundreds of thousands of patients who are going to receive this in the real world. So trying to understand safety and efficacy and impact on variants, and also get data on patient populations who are not treated in the clinical trials, so pediatric patients, pregnant women, getting some additional information about real world use, and then ideally being able to develop risk stratification models to be able to tailor therapy in the future to high-risk patients who are likely to benefit the most from this therapy. I think one of the things that we hear over and over again, and that was also detailed in the white paper, is really the challenges, but also the critical nature of the referral process. As we know, timing is everything. Timing is key. The EUA allows for 10 days from symptoms to treatment for high-risk patients, but we know that earlier is better. So it really starts with that pre-education piece. It's letting the patients know the availability of the treatment if they're high risk. The message has been since the beginning of the pandemic: if you're sick, stay home unless you're really sick, and then go to the hospital. But now it's if you're slightly symptomatic and you're high risk, go get tested quickly and then go talk to your provider. So it's really that pre-education piece that individual providers and health systems at large can really do to start that process of letting patients know of the availability, and having that trusted information come through their providers is really key, as was discussed before. And then I think another piece that there are some gaps and some work to do is really providing information at the point of testing as well. That testing is a really critical part of that referral pathway. And now that there are options for those particular high-risk patients to combine some of that information with testing as well too. And then again, just maximizing the number of administration sites. As we talked about, any one site may not have the ability to have throughput, but getting a number of different sites from the hospital to the home. And to that effect, what we've tried to do is open up the ability of different types of sites to obtain product. While we still have the state allocation system, and we have the speed direct allocation system, which we've heard about a number of times, which is really a critical program to be able to get product to our highest risk patients. We have also opened up so that essentially infusion centers, urgent care centers, physicians' offices, those facilities who have the ability to provide product under the terms of the EUA are now able to obtain that outside of the state allocation process. So we think that will really create some increased access, really that is critical, and provide the ability for a number of different types of locations. So again, we appreciate the collection, and some of our favorite calls is really getting on with different sites who have these best practices, and then sharing them with other sites, because that's really what it's going to take to move the needle forward, and really to understand and realize the maximum benefit from this therapy.
Yeah, and just to follow up on that, Meredith, on the last point, so now 3 pathways for providers who can support access to monoclonal antibody infusion for them to get it. One is through the state coordinated plans. We heard about how Texas is built on that program to try to assure access around the country. And in our report, we have some other examples of states that have taken steps like that, Maryland, others. The second is the SPEED program for particularly targeted to some of these higher risk, likely underserved populations, nursing facilities, community health centers, as we heard about earlier. And the third is this newer access. Can you say a little bit more about how a provider would participate in that program? There's a website they can go to. They need to get in touch with HHS. How do they go about doing it?
Right, sure. So I can provide the information. There is information on the PHE website about that. So essentially and again, this is targeted to infusion centers, physician specialty offices who have infusion capacity, urgent care centers. Essentially what they need to do is go to the distributor, and there's a direct link site for ABC. Which is the authorized distributor, and they would provide either a board of pharmacy license, or if that's not available, they can provide a physician letter of authorization. They will essentially attest to the fact that they are able to administer the product under the conditions of the emergency use authorization, and those will be verified and product will be shipped to them. For all sites who receive government procured product, they will be required to report on utilization, and that's just essentially so we're understanding that we're providing product to sites who are able to use it and really maximizing the benefits.
Great, thank you. And it would add that we'll have a reference to that in that Duke-Margolis report issued, and in also these additional targeted one-pagers that we plan to issue later today for providers like the ones that you mentioned. Rob, I would like to go back to you. Meredith talked about the importance of additional, so you talk a lot about the clinical trial evidence and getting that out there and reviewed and acted upon for guidelines faster. Meredith also talked about the value of real world evidence in this context. That's something that we talked about some in the report that you authored with us recently. Can you say a little bit more about how that might work for questions like safety, side effects in the real world, which we're hearing from people today have been low, but certainly is an ongoing question, effects and or learning about impacts in additional populations and dealing with the effectiveness in variants as well.
Yeah, you know, Mark, I always feel compelled when this comes up to just point out the best evidence would be randomized real world evidence. So yeah. I think these rapid, pragmatic RCTs done to compare a new cocktail versus an old really important. But I know you're referring to the observational real world evidence. And you know, in a little group that's been put together with Google and a bunch of medical centers, we have a bunch of very large cohorts now with outcome data. It looks just like, you know, very low complication rates, very low hospitalization rates. I mean, how often do you see a treatment effect of 80% or more in randomized trials? It's really remarkable. But as we get into this next phase, every time we introduce a new variant or a new cocktail, we're going to need the same kind of evidence. So just as Meredith said, just collecting the data in a standardized way and not highly complicated data, the main outcomes and of the populations would be a tremendous service. So I hope we will have networks that will make that happen. And I know several are underway now.
Great, thank you. And Mary, if I maybe go back to you on the topics that Connie brought up as well related to sufficiency of reimbursement. Now, the Assistant Secretary for Preparedness and Response Office at HHS has been involved in some pilots that aim to use home infusion providers in underserved areas to reach hard to reach patients. Anything else you can add about the pilots or other activities underway now to help develop some better evidence on effective, cost-effective ways to provide better access for those populations?
Right, so there have been a number of different pilots in different settings. So the one that was mentioned, the CVS Quorum, there are also some sort of sites that are sort of pop-up sites that happen as well, sites in long-term care facilities, as long as the home infusion as well. ASPR HHS has also undertaken several community sites, federally supported community sites. One in El Centro, one in Arizona, and then one in Nevada as well. And for those three sites, they were federally supported, but with a lot of community efforts and community involvement as well. They had about 1,000 or so infusions throughout those sites, and with the initial federal support. But all of those sites have then gone on to, in one way or another, continue that work. So I think it really just attests to the involvement of the community. I know that was brought up on a number of different occasions. You know, really using those grassroots to be able to involve all aspects of that referral process. And we've also seen that as well too with the FQHC program, with the SPEED program that is also focused on the FQHCs as well, and really leveraging those community relationships to be able to make this referral pathway as seamless as possible.
Yeah, we've seen some good examples of how to do that as you described. Connie, maybe go back to you. Any additional thoughts based on what you've heard about how to accelerate the effective use of home infusion access to monoclonals for patients who need it?
I think right now our biggest barrier is really just making it financially viable for the providers. I think the data comment is taken to heart with the home infusion industry. We've seen really good response times with the providers that are serving the SNF patients, about 4 days from symptom onset to infusion. And I think that Bill is seeing similar response rates with the home infusion patients. So I think it's showing that home infusion is a good option for patients who need quick treatment, can't transport to another center. It does take an investment though, of additional resources to make that happen. Outcome wise in the SNF patients that we're collecting data on, very consistent with what other data has been presented today, very good outcomes, very low incidence of adverse events.
Great, thank you. And we're just about out of time for this session. You all have covered a lot of ground. I wanted to maybe go back, see if there one more chance for Rob, Connie, Meredith, any final comments that you'd like to make. Rob, maybe you can turn to you first.
Yeah, I noticed the last question here in the chat box about administrative fees in the emergency room. So I hope in the follow-up we'll address that. Great way to ruin a great treatment is to have all these extra costs that were not advertised ahead of time that scare people away. And for, again, I've been around 40 years looking at therapies, and, acute MI was 1980. This is the closest thing to it, an 80% treatment effect. I just want to urge everyone to get the data in, because I think that if the professional societies got behind this, in addition to all the great things that have been discussed here, you'd have a lot better acceptance by the primary care docs and others who have to talk to the patients and urge them to participate. But otherwise, I think the nursing home effort, maybe we're developing a model here for what should happen more often in those settings. So that's very encouraging.
Yeah, and that definitely needs to happen quickly given the pressure of the pandemic. And on that out-of-network billing issue, as you all know, Congress recently passed legislation intended to address that. And as we've heard today, there are a lot of models for providing effective access to antibody treatments that don't involve those kinds of extra charges. Connie, any final comments from you?
I think the only other thing I would add is, that states can play a significant role in providing education, getting word out to patients. I think at the point of testing is the right place to start, making patients aware of their options.
Yeah, it's a really good point. And in our report today, we do provide some examples of states, including Texas, that are taking steps like that. Meredith, final thoughts?
Again, I just really encourage to hear all of these best practices from these different site locations. Look forward to amplifying all of those. Again, please know supply is not an issue. This is something that we've got a tool we can use now, and now is really the time to use that, both for patient improvement and decreasing the support or the issues on the hospital system. So, and if there's anything else that folks would like to be able to see addressed, please let us know. We're happy to engage and really look forward to feedback.
Great. Thanks to you and your colleagues in the federal government for the support for these very timely efforts. And let me extend that thanks to everybody who was on this panel today, as well as all of our speakers and moderators for a very packed 2 hours on the state of the art, the challenges, some of the promising practices, and the issues going forward with respect to antibody treatments for COVID. As you've heard, these treatments have a significant and growing role in reducing complications and hospitalization complications in high-risk patients who are recently infected. They look like they'll be a key element of our efforts to return more towards normal, alongside widespread vaccination, continued vigilance for variants and outbreaks, and enhanced availability of antibodies supported by strengthening evidence, potentially antivirals as well, to limit the consequences of COVID in patients who haven't been vaccinated or who don't have an effective immune response to vaccination. We've described how these antibodies may need to evolve with the variants, but altogether, this makes for potentially a key element of COVID-19 containment, not only in the coming weeks, as we still have tens of thousands of patients hospitalized per day who could potentially have been assisted by these therapies, but also for COVID-19 containment in the longer term. So I would like to thank the people who helped make this event possible, our Duke Margolis team, who also put together the report issued today, the report on evidence issued last week, and again, look for it, the coming one-pagers for different providers and participants, players in this effort to set up new models of care involving antibodies and effective early intervention to prevent the complications of COVID in people who are at high risk. That includes Marta Wazinska, Amy Tourson, Anna Zawadzki, Kirk Williamson, Morgan Romine, Patty Green, and Luke DeRocher. And I'd like to give a special thanks as well to Arnold Ventures for providing the funding support in a timely way that made these activities possible. To all of you who joined us today, thank you for joining. Thanks for your comments, and thanks for your continued efforts and interests in around containing the COVID-19 pandemic. We hope you all have a good day.